Hello everyone, this is Rasha. I hope you're having a great day, and this is another case where ultrasound made a big difference in the care of the patient in the emergency department. So if you still have any doubt that ultrasound makes you a better healthcare provider, I hope this case is going to change your mind. So this is a 63 years old female who was transferred to our facility from an outside hospital for possible non-ST elevation MI and might need to go to the cath lab because she's hemodynamically unstable. So, from the history provided, this is a 63 years old female, and it was her birthday. She was at church. She doesn't have any past medical history. Her family and friends threw a surprise party for her. And shortly after that, started having chest pain and had a syncopal episode. On the evaluation in the outside hospital, her first EKG was negative, and her vital signs were stable, and her first troponin was negative. During her ER visit there, she had ongoing chest pain and a repeat EKG was obtained showing diffuse ST segment depression. The patient was empirically started on heparin and was arranged to be transferred to our facility. Just prior to transfer, her mental status continued to deteriorate and therefore intubated prior to transfer. Shortly after intubation, she was becoming more and more unstable and hypotensive and was started on a dopamine drip prior to transfer. So on arrival to the ER, she was intubated and she was on both dopamine as well as a heparin drip. The first thing we obtained was an EKG, and this is her EKG that was obtained in the department. You can see this ST elevation in V1 and AVR with a diffuse ST segment depression throughout the leads. The cath lab was activated. In the meantime, we decided to perform a bedside ultrasound to evaluate the left ventricular function. Given the patient's negative past cardiac history with these EKG changes, our main concern was the patient in cardiogenic shock, and we might need to change the pressor from dopamine to dobutamine. So this is the first image obtained. So this is a parasternal long view, and you can see the first thing that struck me was this left ventricular function doesn't really explain the hypotension and the pressor requirements in this patient. Therefore, I decided I need to really evaluate and look hard for other pathologies. And what is very obvious here is this hyperechoic line in the ascending aorta. Even the ascending aorta looks a little bit generous, but definitely this is abnormal, and it's concerning for an aortic dissection. I'm just going to demonstrate side by side what a normal parasternal long view looks like, and this is the parasternal long view in the patient. And you can clearly see this hyperechoic line concerning for an intimal flap. So the next step was to actually try and identify, is this real versus is this an artifact? And the next area of the aorta that was easily accessible and we can easily evaluate is the abdominal aorta. Therefore, we performed abdominal aorta evaluation. So this is a longitudinal view of the proximal abdominal aorta, and you can see there is this hyperechoic line within the lumen of the proximal abdominal aorta, which is concerning for an intimal flap. This is just side by side. Here is a normal proximal abdominal aorta, while here is the image obtained in the patient. So we have two views that shows there is this intimal flap within the lumen of the aorta, which is concerning for aortic dissection. This is a bonus image for users of ultrasound. This is a suprasternal view, and you can see this is the arch of the aorta, and you can also see this hyperechoic line within the arch of the aorta. Just going to demonstrate side by side. This is a normal suprasternal view, while this is the image obtained in the patient, and you can see the concerning intimal flap within the arch of the aorta. So with the ultrasound, we totally changed the management of the patient. The heparin drip was stopped. We immediately consulted cardiac and vascular surgery, and in the meantime, the patient, we tried to optimize the blood pressure control and make sure that she's not hypertensive, and a stat CT scan to confirm this diagnosis was obtained. And these are representative image of the CT scan. You can see this thoracic dissection within the arch of the aorta. and it was extensive. It's starting from the root of the aorta all the way to the common iliac arteries. And here on the left side are representative images from the ultrasound obtained. So using the bedside ultrasound, we were able to make the diagnosis of a type A aortic dissection, which was confirmed by the CT scan. So the patient was emergently taken to the OR and had emergent surgery, uh, and her hospital course was prolonged and complicated by anterior cerebral artery stroke. She slowly started to improve, and by the time she was discharged, she was still on a tracheostomy and a PEG tube, but she started to progress with physical therapy as well as occupational therapy. So this is a great example where ultrasound helped totally change the course and the management of a patient and probably save the life of this patient. I hope this was helpful. Please send us feedback and let us know if you have any questions.